So we scheduled the last piece for me to just give you a few comments. I thought I would summarize or share some of the quick highlights that I had from the last 2 days now. Big chunk at sort of the beginning around reducing provider burdens. I think Dr. Hlomka was pretty clear about that. We should celebrate the success of where we were with HIT and acknowledge meaningful use, kicked everybody and got a lot of things going. But I think he also made it really clear that it's time for innovation to creep back in and that we need to make sure that that innovation can happen. There was some pretty good discussion about the role of social determinants, and I think that the role that they play going forward is going to be increasingly important. I think that was clear in Tim Becker's presentation about what the state's done in Michigan to really make health and human services kind of both be taken into consideration at the same time. I think we heard when the Price Waterhouse folks talked about this consumer space is a game changer. There's a lot of interesting, very different things there that need to be paid attention to, because as we get data liquidity and patients start using their information and expecting to be able to do that, the demands and the opportunities are both going to change. We had a lot of stuff yesterday on alternate payment, the state innovation model, a lot of those kinds of pieces, which I think you should take a big inhale. We did all that meaningful use stuff. I think this alternative payment stuff is going to be equally daunting and demanding, and so you probably ought to take the pause while we have it. Today, Dr. Kendrick spoke about HIE futures and the possibilities, and what I loved was sort of the re-emphasis on, the power of ADTs. Most folks underestimate that transaction set, and I think it's becoming increasingly clear that it's not the entire medical experience, but it is a very good key for you on a number of fronts to do sort of alerting and triggering really important events. We did a lot of stuff on quality, a little bit yesterday and also today. Quality measures, where that has to go. We heard about practice transformation, telemedicine. We looked a little bit about public health in terms of the public health opportunity with Dr. DeSalvo and Carla. We heard from some of the national players trying to figure out how things work together at a national level. I was both encouraged and disturbed because it sort of is coming together, but you can still see there's going to be plenty of fragmentation. The world is not going to simplify. It's actually going to get more complicated, but we are getting better at sharing things and in a way sort of managing some of that diversity, but it's going to keep coming. There was the panel on the learning health system, which is another thing that people are going to start having to figure out, which is actually measuring how fast and how quickly they're learning and what they've learned. And then a little bit about where's the value proposition. And it's not all about this technology. We've actually got to do a better job with sort of communicating and preparing people. So I will wrap up with just a few slides before I thank everybody and let you all go. In articulating to my leadership team, what's the problem? Who's the enemy? Who are we fighting when we get up in the morning? I am more and more convinced that the status quo in healthcare is enemy number one, and that it has to change, and that's the battle, and that's the enemy. So where do you start in something as overwhelming as that kind of enemy and as pervasive? And I think there's some obvious pivot points, and the pivot point, the weak spot, is where we have burdens on providers and ultimately patients too, waste, and wherever somebody gives you resistance to change, okay? It's because in that resistance to change, there's something good there probably, but at the same time, if there's waste and burdens, that is an important place to sort of poke. On the other side of that, you have bad technology. And we have a lot of bad technology, and I define bad technology as something that probably requires a human in the loop to solve it. It can't be automated or is basically not interoperable. So if the solution is if the only solution is to put up a web portal and tell somebody to stop what they're doing and log into it, that's a good sign that you've got insufficiently good technology. That doesn't mean the portals are bad. It just means you need an electronic way to alternatively get at that same information. Maybe a better way to say it is your technology is not good enough yet. And then wherever you see a lack of standardization, which if there was ever a poster child for that, it's quality measures. Again, there's really not a consistent approach about how that performance is evaluated across health plans. There are many other opportunities. But if you get this formula, this is where we have to fight the status quo. Now, I would like to recommend that a successful path for MiHIN and probably in other places has been to start in the public health domain, possibly in the future that will be in the population health domain, because it's hard to fight the greater good in those spaces. The politics are not, you know, they're real, but they're less severe, and usually it's a safer place to start. And then you can move into care coordination type areas, and then you can move into official sort of quality improvement type spaces. And what you've really done, if you manage to get those three lined up, is you've positioned yourself for the payment reform components. So what you've done is you've created a line to the money. And what ends up happening pretty quickly is you get those pieces starting to spiral, and you've now really circled your wagons to be able to do stuff in the consumer space. And ultimately, everything we're doing is aiming at the consumer space. We're kind of finding our way to it in a spiral, but we're really trying to get it tooled up so eventually, you know, consumers can have access to their own information, even if they just want to turn around and give it back to doctors and providers. Now, Claire asked a question about how do people do stuff with active care relationships, and I want to put forward something that's fundamental to what we're doing in Michigan, and I think is sort of galvanizing in more places, around master data, around the data that's necessary to connect the dots. It was encouraging to hear what Mike said about one of the big things is I just need to know who to call or who else is doing this. And for us in Michigan, it's essential, in MiHIN in particular, this connection between what we've historically called the provider directory or the list of providers, this active care relationships, and the bridge of those active care relationships to consumers or to patients in their family. It's a map. It's a map to help us figure out how to deal with the fragmentation in healthcare. And that map, when our team member from Orion talked about Cassandra, which is kind of the new, a new technology that said, how do we handle massive data of varying types? This active care relationship structure is what I would consider attribution of the future, and parts of it are here today. And what it does is it starts to let you build very simple pairs of linkages. This doctor is connected to this patient. This hospital and this patient have been connected within the last 30 days. This long-term care facility, this home health entity. Very simple pairs that when you then process them, you can kind of pull out the thread and say, oh my gosh, this is the entire star pattern that the patient is connected to. But it gets interesting because you can start making attributions to particular diseases or exposure or to where a patient's data home is. If you look at sort of what Dr. Kendrick talked about, it allows you a very simple data structure that's very, very scalable to very quickly find out where you have to go and link to consumers. And it can include where consumers want their information to go, which is ultimately leading to preferences. We have this infrastructure in Michigan now. But it looks, because MiHIN is about infrastructure, not necessarily a longitudinal medical record, it looks like all these directory services. These are the things that are on the internet, help you find your way around and connect stuff. It's why Google works when you query for things or when you pull down apps. And you can begin to build around these directory services use cases that enable care coordination, use cases that support quality measurement, and you can do them both off the same shared infrastructure. And this is the power and the magic of sort of where I think things are headed here. And it gets better because that same core infrastructure, FHIR-enabled or traditional ways to get at it, also helps you keep track of a lot of these workflow things. Who's in my ACO? Which one of these crazy advanced payment formula things are we in? How do we sort people out? Who's on board with our process to get them into this new program, whatever that program is? And then finally, it's the same infrastructure for how you begin to identify and link to consumer preferences. And very quickly, you can begin to build out a series of things around this infrastructure that, again, it's infrastructure. You still need good workflow tools on top of this, which is what the HIEs in Michigan do, the different products that EHR vendors do, but you can leverage this infrastructure to kind of let this connectivity piece show up in the work stream that you're most comfortable with. And by connecting the infrastructure together, you're linking the payment process, the public health process, and the care delivery process in ways that, frankly, they've historically been kind of different silos or different streams, okay? And as SIM moves into the community, this infrastructure is going to become more and more important. So we talked about ADTs. Very quickly, people are understanding ADTs are not just about transitions of care. They're about telling you who's connected to whom and what are the demographics associated with an individual. You still need to get population, patient lists, patient rosters as part of your active care relationship service, but you can also use these ADTs, because an ADT is an HL7 message that happens in an EHR anytime somebody touches the patient. There's kind of an HL7 message or ADT generated. So it's not just hospitals, it's not just long-term care. It happens in an ambulatory setting. It happens in almost any modern system now. There's an HL7 message. And so that infrastructure starts to scale and become quite interesting. Now, we mentioned a couple times the common key service. We are doing something in Michigan that is a little different. It is an outgrowth of what some of the national best practices on white papers have said, is that it sure would be nice if we had an additional identifier that everybody kept, okay? Not necessarily the only identifier, because we're not shooting that high, but another identifier that when I was going to share, in this case I might be a provider organization, when I was going to share with data with somebody outside of my organization, I just included that other key. And when we tried to put the data together, the matching process got a little extra boost. And so we have a pretty substantial initiative in Michigan to do this common key service. And it takes the sort of 9 million active care relationships that we have, and we bang them up against the state's MPI, Master Person Index, and we assign these common keys, and then we kind of push back the ACRES information to the folks who've given it to us with these keys on it. And then we also, for the folks who don't really manage populations quite this way, they're a little more transactional, like hospitals and long-term care facilities, we kind of save up their ADTs, and we kind of build them an active care relationship list of all the people who've been there in the last 30, 60, 90 days. And then they're an ACRES file, and we bang that up against the MPI and give them assigned common keys. And a handful, Jeff mentioned a pilot. The pilot sort of worked out a pretty elegant way to kind of passively send that information back to those organizations so they keep this foreign key that they can essentially start tagging onto all the messages and the future ADT messages that they send back out so people can match better. Okay? Don't have to use it, which is what's nice, but as you trust it more and more, your match rates get higher and higher. And suddenly there's an additional component in the infrastructure that just makes everything else better and more accurate. which when you go into a consumer space and you start releasing information to consumers becomes even more important. You really need to know who the consumers are and that you're matching the data well in that space. Okay? This acres common key thing suddenly gets interesting because even in situations where you're trying to do closing gaps in care in the quality space, and I think, again, Dr. Kendrick made a really nice point, nobody's got a complete picture of the quality situation. Now, our approach in Michigan is a little different than what he listed, but essentially if a physician organization sends in their supplemental clinical information and then we go through that sort of quality matching process to send back the gaps in care, the gaps in care can go back to the PO and then they can say, okay, here, closing the gaps in their next feed. But another opportunity that suddenly opens up is that we can actually take that active care relationship list and we can send those gaps in care to everybody with an active care relationship with the patient to get them closed. And suddenly you are actually tackling the whole puzzle versus just trying to get one individual place where you get your quality gaps closed. So where I see things headed, and this is something that I think you're going to see advocated for on a large scale in a number of states, is that we've really got to simplify the way data is sent out. And we've learned a lesson with ADTs, and we're going to see it nationally. We're starting to see it nationally, where, you know what, just send those things all the time to the same place. Okay? There's no cognitive burden here about route this one that way and route that one that way. Take the burden off a provider organization and say, whenever you touch the patient, bang, send an ADT. We're doing something right now with care summaries where very quickly we'll be in the 90th percentile where all of the hospitals upon discharge are sending a care summary. Okay? Well, it's looking to me and it's looking to other folks that, you know what, let's just create an infrastructure where when you finish seeing the patient, whatever that definition is, send a care summary. Send it to the same spot and just do it every single time. And in the quality space, we're seeing as people get closer to arriving on a Category 1 quality measure as a real thing, just on whatever interval we agree to, send the quality measure. Suddenly, the crazy interfacing madness that most folks have starts to come off the table, and we have greatly simplified the entire data exchange process because we're saying send it. And send it every time. And then we take the active care relationship infrastructure and we route it to places. We might route it to Great Lakes and they put it in their longitudinal record, which is happening a lot with these care summaries and things and ADTs. Or we might route it to all of the interested doctors who have an active care relationship. Or we might route it to the consumer-mediated platform that the patient has said, please send all my stuff to my Apple Care Cat. Doesn't really matter because we got an active care relationship to tell us where to send stuff. I've got labs up here and I've got public health up here because they're not fully well represented in a CCDA right now, but over time I think they will be. But we could do the same thing, just send all the labs. And probably the simplest thing to do in the short term is just say, yeah, send all the labs. It radically simplifies the strange logic and the contortions that people are paying money for in their EHRs for these interfaces. So you say, well, what if I don't know or I want to go get information? Then what I think happens is in the record locator world, it's been very painful because it's been combinatorially explosive. It means basically if you see Tim Pletcher for the first time and you say, I need information for Tim Pletcher, you kind of have to announce it to the world and broadcast it to every possible place. It's one of the biggest criticisms about record locator services. Well, now, with a mature active care relationship infrastructure, suddenly you have a roadmap of every place you might want to query for that information. And because we keep a directory of all the electronic service information of all the EHRs and all the places and sort of how they're connected, suddenly you use this service to have a very constrained record locator service. You know exactly where to go, And if you have a smart query kind of infrastructure, you can start to rule out the places that don't fit the criteria for the kinds of things that you're looking for. So I'm fairly confident that this is what the next generation looks like, because in order to pay people, you have to, in a world where there's sort of pay performance, and you've got to divide the money among all the different players, your care coordination and your payment infrastructure and your active care relationship infrastructure all kind of have to be well understood, well managed, and really synchronized. So you have to build this infrastructure anyway just to go into this sort of payment reform space. So it's a kind of a triple whammy. With that, I would thank all of you. I am happy to stick around for questions. I truly appreciate the turnout. I want to give a round of applause to the MiHIN staff, our interns in the back, please. David Livesay and the Marcom team. I don't know where David has gone to be hidden at this point. I see Sam here. Where's this Dave? Our sponsors are great speakers. We've had just an awesome lineup. Karen DeSalvo, the HIMSS team, and all of you. We have sold out workshops tomorrow, one on fire, one on quality. If you're desperate to sneak your way in, come talk to one of the MiHIN folks, and we'll see what we can get figured out for you. Great lineup of folks who are going to get kind of in the weeds on some of this stuff. You may have thought we were in the weeds a few times during the last 2 days. If your head is not so full, go tomorrow, and it will be overflowing. So thank you all very much. Have a safe journey home if you're going home. Otherwise, we'll see a bunch of you tomorrow. Bye now.